Assalamu alaikum. I'm Dr. Sobia Mehreen, resident of Cardiac Electrophysiology at Armed Forces Institute of Cardiology, and I will be moderating the electrophysiology session of the 24th Annual Cardiology Update today. I request the distinguished chairpersons to take their respective seats at the podium. I request Brigadier Azmat Hayar, Professor of Cardiology and Electrophysiology and Deputy Commandant FIC, to come at the stage. Professor Javed Akbar Sial, Consultant Cardiologist at NICVD Karachi. Professor Shehbaz Qureshi, Consultant Interventional Cardiologist. Professor Nusrat Ara Majid, pioneer female cardiologist in the country and Consultant Cardiologist at RIC. Professor Harun Babar, Consultant Interventional Cardiologist. And also General Khurram Shehzad, ex-Commandant FIC Rawalpindi, to come on the stage. I now request Dr. Zahoor Ahmed, Associate Professor and Consultant Cardiac Electrophysiologist at HMC Peshawar, to enlighten us about approach to tachyarrhythmias.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, respectable panelists and colleagues. And thank you very much for inviting me and giving me this opportunity. Sorry for the delay. So I'm going to talk about how to approach patients presented with tachyarrhythmias. So the learning objective of this presentation is that the participants should be able to distinguish and explain the various types of supraventricular tachycardia and ventricular tachycardia. And they should also be able to recognize the various patterns of supraventricular tachycardia and ventricular tachycardia on the ECG.
डॉक्टर साहब जरा ऊंचा बोलेंगे, थोड़ा दिक्कत है आपकी आवाज समझने में.
So the tachyarrhythmias are broadly classified into a narrow complex tachycardia and a broad complex tachycardia. The narrow complex tachycardia is further classified into a regular one and the irregular one. The regular one includes the sinus tachycardia, the atrioventricular nodal retentive tachycardia, the atrioventricular reciprocating tachycardia, the orthodromic one. This is the one in which there is antegrade conduction through the AV node and retrograde conduction through the accessory pathway. Atrial tachycardia, atrial flutter with a fixed ratio, and junctional tachycardia. The irregular one includes the sinus tachycardia with premature atrial contractions and premature ventricular contractions, atrial fibrillation, multifocal atrial tachycardia, and last but not the least is the atrial flutter with variable blocks. So this flow chart seems to be a very busy one, but it's pretty straightforward and very simple. The narrow complex tachycardia is the one in which the QRS complexes is less than 120 millisecond. Whenever we come across the ECG with the narrow complex tachycardia, the first thing we have to confirm it's a narrow complex or the broad complex. The next step is to look for the regularity, whether it's a regular one or irregular one. The regular, if it's regular, then the next step is if there are any visible P waves or not. If the P waves are not visible, then the diagnosis is atrioventricular nodal retentive tachycardia, and the mechanism is that there is simultaneous activation of both the anterior ventricle. That's why P wave is buried in the QRS, though ventricle is not a part of this tachycardia. If the P waves are visible, then the next step is to look for the atrial rate. If the atrial rate is greater than the ventricular rate, then the diagnosis could be atrial flutter or atrial tachycardia. If the P waves are not visible, then we analyze the RP interval. The RP interval could be a short RP, that is the RP interval less than the PR, or it could be a long RP if the PR is longer, if the RP is longer than the PR. If in short RP tachycardia, the RP will be shorter than 70 millisecond, and the diagnosis with AV-NRT AVRT, and atrial tachycardia. In lung RP tachycardia, the most common and the three differentials are the atrial tachycardia, permanent junctional reciprocating tachycardia, and it's a type of tachycardia which most commonly occur in infants and the children, and it's a very incessant tachycardia. And the last one is the atypical AV NRT. Here is the concept of the short RP and the long RP tachycardia. Here you can see this is the RP and this is the RR interval. If the RP is less than the half of the RR interval, it is a short RP. And if the RP is more than half of the RR interval, it's a long RP tachycardia. Now, coming to the wide complex tachycardia, the wide complex tachycardia, the rate will be more than 100 beats per minute. There will be a wide QRS complex that is more than 100 milliseconds. And it should be measured in the lead with the widest QRS complexes. If there are more than 3 or 3 consecutive PVCs, this is the non-sustained ventricular tachycardia. And if the ventricular tachycardia is more than 30 seconds in duration, it's a sustained one, sustained ventricular tachycardia. Ventricular tachycardia could be a monomorphic or the polymorphic. In monomorphic, there will be a single morphology, and most of the idiopathic ventricular tachycardias, the ILVT, the outflow tract VTs, these are monomorphic ventricular tachycardia. In polymorphic, there will be multiple morphologies. The wide complex tachycardia is further classified into a regular and irregular one. The regular one includes the monomorphic ventricular tachycardia, SVT with aberrancy, SVT with pre-existing bundle branch block, antidromic AVRT. This is the one in which there is antegrade conduction through the accessory pathway and retrograde conduction through the AV node. And pacemaker-mediated tachycardia, which occurs in patients with dual-chamber pacemakers, and anything which disturbs the AVA or the VA interval that leads to pacemaker-mediated tachycardia, and the remedy just to increase the PVAR, the post-ventricular atrial refractory period. Similarly, severe hyperkalemia with sinus tachycardia and tricyclic antidepressant toxic can give rise to wide complex tachycardias. The irregular one includes the atrial flutter and atrial fibrillations with aberrancy and pre-existing bundle branch block, and with pre-excitation and polymorphic ventricular tachycardia. So the wide complex tachycardia is the one in which the QRS duration is more than 120 milliseconds. The next step is to look for whether it's a regular or irregular one. If it's regular, then go and see the QRS morphology, whether the QRS morphology in the sinus and the ventricular tachycardias are the same. If it's the same, then it could be SVT with bundle branch block or antidromic AVRT. History is very important because most of the patients, those having the history of myocardial infarction, in these patients, the tachycardia most likely could be ventricular tachycardia. The next step is to look for the one-to-one relationship. If yes or unknown, then we go and look for the QRS morphology. And if there is typical RBB or LBB, there's SVT. And these are the morphologic criteria for the VTs I'm going to discuss in the next slide. If there is no relation one-to-one, so if the V rate is faster than the A, it's a ventricular tachycardia. If not, then it's atrial tachycardias. There are certain algorithms which are developed for differentiating the supraventricular tachycardia from ventricular tachycardias. These are Brugada algorithm, the lead to R wave peak time, the AVR algorithm, and the Bayesian algorithm, and the Griffith algorithm. But the most commonly used algorithm for differentiating the supraventricular tachycardias from the ventricular tachycardias is the Brugada algorithm with a sensitivity of 89 and a specificity of 59.2%. Here is the Brugada criteria. And it consists of 4 steps. The first step is to look for the absence of the RS complex in the precordial leads. If the RS complex are absent, then the diagnosis is pretty straightforward. It's a ventricular tachycardia. If not, then we look for the RS interval. If it is more than 100 millisecond, then it's a VT. If not, then the next step is to look for the AV dissociation. And if there is no AV dissociation, then we look for the morphologic criteria, whether it's a RBB or LBB morphology. Here we can see that there is a broad complex tachycardia with absence of the RS complex and negative concordance. Here is the, we can see the interval is more than RS, more than from the onset of the R to the S wave is more than 100 millisecond. And here is the dissociation of the atria from the ventricle. So these are all the hallmarks for diagnosing the ventricular tachycardias. These are the different morphological criteria for diagnosis of the ventricular tachycardia. In case of the right bundle branch block, in V1 there will be a monophasic R wave or QRRS pattern in V1. There will be a QS, QR, and the ratio of the RS less than 1 in V6. Similarly, in to look for the left bundle branch morphology, the duration of the R wave should be more than 30 milliseconds. There will be a stroke, there will be an S wave in the downward stroke of the S wave, and the duration from the start of the R to the S is more than 60 milliseconds. And there will be a QR or QS pattern in V6. Here is the AVR algorithm for diagnosis of the ventricular tachycardia. These are the 4 steps over here. If there is initial dominant R wave, or if the duration of the R wave is more than 40 milliseconds, or if the duration of the S wave is more than 40 milliseconds, or if there is a notch in the downward stroke of the S wave, any one of these then diagnose the ventricular tachycardias. There are certain narrow beats in the wide complex tachycardias. The capture beats and the fusion beats. The capture beats occur when the SA node, sinus node, transiently captures the ventricles in the midst of the AV dissociation to produce a QRS complex of normal duration. And fusion beat is the one which occurs by the sinus and the ventricular beat. Here you can see, here is the fusion beat, same like in between the sinus and the ventricular beat. And here is the capture beats which manage to travel to the ventricle and depolarize the ventricle. So coming to how to treat these patients then. In a regular SVT, the first step is the vagal maneuver or IV adenosine, which is a class 1 indication. If it's N effecto, then the next step is to look for which the patient is hemodynamically stable or not. If the patient is hemodynamically stable, then the next options are the beta blockers, calcium channel blockers, which are class 2 indication. If N effecto, then synchronized cardioversion. If hemodynamically unstable, then the treatment of choice is synchronized DC cardioversion. But in my practice, if a patient presents with a supraventricular tachycardia and hemodynamically unstable, then I usually administer the IV adenosine and which reverts the tachycardia. This is the ongoing management of the supraventricular tachycardia. If the pre-excitation is present or not, if the pre-excitation is present and the patient is willing for EP, then catheter ablation is class 1 indication. If not, then medical therapy. If the medical therapy is ineffective, then catheter ablation again is the last resort. These are the various pharmacological options for these patients. The beta blockers, the calcium channel blocker, these are class 1 indications. And flecainide or propionone class 2 indication if in the absence of the structural heart disease. Similarly, amiodarone and digoxin, these are also class 2B indication for these patients. Coming to the atrial flutter, if the patient is hemodynamically, to look for the hemodynamically stable or not. If the patient is hemodynamically stable, the treatment strategies are the rhythm control and to control the heart rate. For the rhythm control, the class 1 indication is synchronized cardioversion, and for rate control, beta blocker, calcium channel blockers are a class 1 indication, and cardrone is a class 2A indication. Similarly, if the hemodynamically not stable, the treatment strategies again is the rhythm control and the rate control. For rhythm control, DC cardioversion is a class 1 indication, and IV amiodarone is a class 2 indication. This is the ongoing management of the atrial flutter. Again, the treatment strategies are to control the heart rate and the rhythm control. For control of the heart rate, these are the beta blockers and calcium channel blockers. For rhythm control, the various options are the catheter ablation, which is a class 1 indication, and these are the pharmacological options. If these are ineffective, then the last resort again is the catheter ablation. Now coming to the cases.
Doctor Saab,
Here is a 35 years old.
excuse me. I'm sorry you've already 5 minutes late, so we may not have time for these cases. I'm sorry for that.
Okay, thank you.
Now I request Dr. Talha bin Nazir, Associate Professor, Head of Department of Cardiac Electrophysiology Department at RIC, to update us on the management of atrial fibrillation.
Assalamu alaikum. I hope you guys can hear me. I'll try to be very brief and to the point. So without any further ado, atrial fibrillation, it's a very common arrhythmia, the commonest arrhythmia, not only in Pakistan, but global worldwide. We know that it's more of becoming a global pandemic. And we in Pakistan are not actually, this is an underestimate of what we see, because we've got not only non-valvular, but the valvular forms as well, which are now the obsolete terms, but these are things for purpose of illustration. So AF is something very common, not only in the electrophysiology or cardiology wards that we come across this, we see this in everything, whether it's pediatrics, adults, gynecological wards, and otherwise. So what are we just going to talk about? This primarily presentation is based on the American guidelines, which actually just came out in September 2023. So these are the points that we will just be discussing very briefly. To begin with, classically what we knew of atrial fibrillation was it paroxysmal, persistent, or was it permanent? But the current guidelines, they've actually incorporated the pathophysiological process as well, not only the therapeutic interventions that could be related to the type of atrial fibrillation. So what we see now are with this, if I can just get my laser pointer on, that we see patients who are at risk of atrial fibrillation. Now, these patients have modifiable and non-modifiable risk factors. Then there is the stage where you get the pre-AF, where some structural abnormalities are visible, and you can see them on the imaging modalities. In addition, you can see on them on ambulatory modalities. And then obviously we've got the clinical presentations, which are the classical ones that we know, the paroxysmal, persistent, and then the long-standing persistent of more than 1 year. 3D is a class where patients who have, we see atrial fibrillation sometimes in patients who have undergone ablations. And then if the patient is not amenable to any rhythm control, then we obviously classify them as permanent atrial fibrillation. Now, the beauty of this classification is that it illustrates that, you know, atrial fibrillation is not a pinpoint segregated kind of a thing. It's a disease continuum. And it begins with very small things, exposures to risk factors, which then mimic as atrial ectopy, non-sustained atrial tachycardia, and then they obviously go into the more sustained forms and the more chaotic forms. But throughout this, we can understand that the treatment of modifiable risk factors is probably a cornerstone. And again, the other modalities would definitely help with the treatment of atrial fibrillation. So this is a more of a newer classification, which I think, so for purpose of understanding and making harmony in terms of the approach used between electrophysiologists and otherwise. With this, the second update that came along, which the European Society actually claimed back in 2021, but they considered that the optimization and the incorporation, the prescription and the treatment of modifiable risk factors be considered as a pillar. So things like, head toes meaning like heart failure, exercise, arterial hypertension, diabetes, tobacco use, obesity, ethanol, sleep. These things and sleep disordered problems, these must be addressed not only at one particular time, but at periodic intervals when the patient comes with atrial fibrillation in the clinics. So if these are not addressed, you can see these create the foundations for the further structure and the further treatment plans for patients in our clinics. So make sure it's kind of a reminder that we should not be ignoring, for example, if I'm a cardiologist, I don't want to be just indulged in managing heart failure. I would want to consider sleep disorder problems, classically known as obstructive sleep apnea, snoring issues, because these do hold a bearing on the progression and disease process of atrial fibrillation. So make sure it's a holistic approach that we take towards patients. Furthermore, the guidelines now give us flexibility. Now, obviously, there comes a time when we're in clinics, we are trying to risk stratify patients for thromboembolic risks. So, for example, we're using the most well-known risk scores such as CHADS FAST score, but if I tell you that more than 15 studies have been actually done, and then all of them have shown a wide variation of actually thromboembolic risk. So for example, if someone was labeled intermediate risk, which is considered as a 1 to 2% of a stroke in 1 year, some people could have strokes as less as 0.5%. On the other hand, people with this risk score can have stroke of around about 10%. So it shows that it's not a very perfect score. So whenever there is a consideration that, you're not taking into account all of these risk factors, you may want to attribute and use other scores such as the Atria scores, Garfield scores, and every one of them actually have their pros and cons. I do apologize for the, maybe I'm not sure if everyone can read this, but CHADS FAST, what we can see is that it's the most commonly one. And as we can see, it's the best validated score. So hence we have more confidence in saying that, it's the probably most accurate score that we can get. But obviously it's far from perfection. Then the Atria score, now the beauty of the Atria score is it incorporates other modalities as well, other factors as well, which includes such as age, then bleeding risks as well. It gives you a slightly different angle. But the thing is this, it's less well validated. The Garfield one, obviously it has the effect of other anticoagulants, because what we do is classically we use such as the CHADS FAST score, we use the Haspled score, the hemorrhages score, but the hemorrhages scores and Haspled scores have their own downsides as well. So these scores, when used in concert with each other, can give you a more accurate and more precise form into thromboembolic risks and weighing the risks and benefits of actually administration of oral anticoagulants. And to pin one thing down, remember as clinicians, what we've got to be careful is it's always a shared decision making. We don't enforce things. We need to take into account the feelings of our patients, and we need to obviously make sure that they are reasonable at the same time, and we need to facilitate the thoughts of our patients. And even in a country like Pakistan, it's doable. I know we are overwhelmed with population and with volumes, but we should make every effort to make our patient biopsychosocially actually at comfort. So with all of this, then obviously stroke risk modifiers, it said that where there is an intermediate to low risk score, you would want to consider usage of additional risk factors that can cause stroke to help you make a decision in order to give or not give oral anticoagulation, or to help facilitate your patient, make a decision. Now, what are these additional risk factors? So higher AF burden, long duration. So it's not just merely saying patient has a paroxysm. Now, there could be a patient who has a paroxysmal atrial fibrillation of, let's say, less than 48 hours. But there could be another patient who could have it up to 6 days. Now, the burden is definitely different, and studies have shown that the higher the burden there is, the higher the chance of a thromboembolic event. So obviously taking into consideration, obviously when you're investing for this, you will need to investigate the patient appropriately. You'll need to do ambulatory ECG monitoring. You might need to put implantable implantable loop recorders. You may need to actually interrogate the device of a patient who has atrial high rate episodes, need to see their duration and obviously verify them whether they're atrial fibrillation or not. Similarly, obviously the additional, is it a persistent or is it a paroxysmal? Then again, obesity. Obesity again is something that obviously makes things worse because it increases the workload, changes the dynamics, the molecular and the cytokines within the body. It creates an inflammatory response. Sarcomeric hypertrophic cardiomyopathy. We know it's a disease process, and then we know at the molecular level, atrial fibrillation is affected by the organelles and the intracellular and intercellular signaling. Poorly controlled hypertension, increasing afterloads is obvious. Chronic kidney disease patients with a reduced GFR, obviously because it's just not about the kidneys. Remember, it's a systemic inflammatory response. And same goes for proteinuria, but again, that creates a prothrombotic state. In large LA volumes, pretty obvious, where you have a structural abnormalities, and obviously these things would hold a bearing on the patient, patient's outcome for thromboembolism. Early rhythm control has been stressed. So as opposed to the old state where we used to say, the AFFIRM trial used to say that, look, rate control, rhythm control is not a big issue. But here, early rhythm control is stressed upon because we understand that AF begets AF. If you nip it in the bud, you get it controlled as soon as possible. You can stop the disease process or at least retard the disease process and obviously improve the quality of life, reduce the morbidity, reduce the number of strokes. Various studies have came out, and actually it's incorporated into the guidelines as well, that rhythm control would reduce the stroke incidence as well. Hospitalizations, heart failure, all of these things are improved. And just this slide is to illustrate the complexity of actually atrial fibrillation. And obviously, rather than getting into a complex situation, it is better to nip it in the bud. There are various trials. In the interest of time, I'll just skip them, but the pivotal one was the East AFNet trial, which actually mentioned, this proved, it was a randomized control trial, it proved that the earlier you get a patient rhythm control, and that too preferably with the intervention, which is catheter ablation, which is quite common in Pakistan and is being done throughout the country, right from north to south, east to west, then obviously these patients do far better than antiarrhythmic therapy. And all of these things point that the earlier the treatment, the lesser the chance of a recurrence. And to the extent that you can consider maybe the atrial fibrillation has a cure chance of almost about a 90-95%, as opposed to the 60-70% in the classical historical ways. So catheter ablation for AF is considered a class 1 indication, and that too over drug therapy. It's not that if drug therapy fails, you consider it. You can totally bypass drug therapy with shared decision making. You proceed toward it. It's not a very kind of a fatal kind of a procedure. It's not a very extensive procedure. No doubt it's complex, but if done properly, it's got a complication rate of even less than 1%. So these are just things echoing the same thing. Similarly, these are trials which have also, mentioned that atrial fibrillation, again, compared to antiarrhythmic therapy, has actually shown better outcomes. Catheter ablation in AF and heart failure has been shown to reduce morbidity, improve survival, reduce hospitalizations, and symptomatology at the most. Again, same things, interest of time. So one thing I would like to bring forward is, and conclude my talk, so who are these patients that actually, I'll just skip to the point, that would have, would benefit from rhythm control. So first, you need to understand atrial fibrillation begets atrial fibrillation. It's a disease continuum, so nip it in the bud. Optimize the therapies. Don't take AF alone. You have to take a holistic approach, address all the pillars, have a shared decision making, give special attention to minimize and prevent disease progression. You need to minimize thromboembolism, and you can take into consideration now additional risk factors. Early referral, early rhythm control. Please don't wait that the LA size will become of a football size and then you start considering for rhythm control. You need to do it well in advance. And if you're a keen observer, you're a keen clinician, you will see these patients very early on. Catheter ablation has been proven to be superior to antiarrhythmic therapy, is available in Pakistan, has all these benefits which it shows, and obviously atrial high rate episodes, patients who present to you with devices that have been implanted, get their devices interrogated. Please don't ignore them. They need to be addressed as well, because these patients sometimes end up coming with drastic thromboembolic problems, and obviously that can be totally disabling and life-changing. Consider left atrial appendage occlusion devices which have been escalated to a class 2A indication where there's a problem with oral anticoagulation. And lastly, patients, for those people who are working in the medical and ICU wards and the surgical wards, we used to think, oh, it's an acute kind of a problem that is due to a lower respiratory tract infection, but it's been shown that in a way, not all patients with lower respiratory tract infection, pneumonia suffer from AF, but those who suffer, they may well have actually recurrences, and 40 to 50% do have that. Thank you very much for your patience.
Tala, Sobia, a quick comment. Tala, I know you're doing wonderful job, and you're mashallah very good at AF ablation. I'm sure by the old standard method and now with the cryo. What is your understanding after successful AF ablation? You have isolated all the 4 pulmonary veins. What do you recommend stopping? When do you recommend, and how do you recommend stopping the anticoagulant? When and exactly, if at all?
Sure. So right now it's a matter of a gray zone.
Because, as you know, this is a big benefit that was in some patient. If you cure, this is a curative procedure. You cure, and then probably you can take them away from anticoagulant.
Absolutely. So this is actually a very difficult question. It's still in the gray zone. We're still ongoing trials going on it, sir. But with the evidence that's coming up, patients with lower intermediate risks, they can be considered having a decision making. And if they remain free from basically atrial fibrillation for the first 2 years, they can have the anticoagulation based on discussion, telling them the pros and cons, because there are so many patients who are actually fearful from oral anticoagulation because of various reasons. So these patients can be discussed with, and it can be considered you can take them off. But as per guidelines, it's difficult to take them off. But you need to put this across and let the patient make the informed decision. Same, however, if a patient is obviously at a lower risk, which means 0 to 1, then these patients after a period of 3 months can be taken off oral anticoagulation altogether.
Yeah, I think I have a quick question. There are 2 scenarios. Here I am, in front of you. Yeah, okay. Yeah, not easily visible anyway. So I think there are 2 quick questions. Number 1, I mean, somebody who's got paroxysmal atrial fibrillation with a small TIA, documented TIA. Now, what would you recommend for prevention? Would you recommend using amiodarone therapy, long-term and low doses, maintenance doses? Second question, about anticoagulation. In these patients, how long do you continue anticoagulation? Is it for lifetime, or is it some limited period?
Sure. Actually, one of the slides addressed one of the questions, amiodarone. So low-dose amiodarone, 100 milligram to 200 milligram per day, is considered a class 2A indication only when other methods of rhythm controlled, which includes ablation, which includes other medicines like class 1C antiarrhythmics, sotalol, propafenone, ibutolide, otherwise, if they have failed because of the toxicities and the side effects in the long run for amiodarone. And especially that would be because obviously we need to appropriately counsel the individuals. In addition, if it's a younger patient, I would be very much avoiding, because I would understand he will be having a very, long-term side. He will be using amiodarone for a very long term. The other thing is this: despite amiodarone therapy, subclinical atrial fibrillation breakthrough is there, which we don't detect.
We don't have any other registered drug in Pakistan.
Sir, absolutely. I can understand that. We are trying on that. But then that's why I say what we consider is, where appropriate, we would be considering if we have a modality available. Again, lots of people ask me, it's a very costly affair, it's nothing. Believe me, I think if I go outside and dine out today, I'll be probably spending more, or most of the people will be spending more over a period of 2 or 3 years on various things which are not essential. But then that is a discussion debate. But having said this, it's not something which is not reasonable, but it should be just kept down the list. other things need to be discussed by the concerned specialist, so he can give them both views, put them in front, and I'm sure any person of any educational level in our country as well can understand it. The only thing is this, as a clinician, we need to give not 1 minute, need to give them 5 or 6 minutes for making decisions and giving them time. The other thing is this, stroke or TIA, it's probably the most feared complication of atrial fibrillation. It would be very difficult to convince myself for the patient to come off oral anticoagulation. Having said this, what's very important is we should confirm what was the mechanism of the stroke, because just having a TIA doesn't mean that it was atrial fibrillation. It can be due to carotid artery disease, it can be due to aortic plaques flying off, it could be the vertebral-basilar arteries, and so forth. So obviously determining the not only ischemic stroke, but the mechanism of stroke is important. But again, I think it will be very difficult in our setups to take a patient off oral anticoagulation.
For the sake of...
Just one question and a comment, Talabai, over here. You know, stroke and AF is a real tricky issue, and we start noticing a pattern. We tend to do a lot of TOEs in 4G Foundation, and patients who have mitral stenosis and who have a clot in LA appendage, we started recording the velocities of the contraction. And we found that those who had a clot had a low velocity and a contraction in the LA. And we're doing the same for atrial fibrillation also. And we put the continuous wave and then pulse wave, and we're noticing that those who have a clot tend to have a poorly contracting LA appendage, and the velocity there is much less. So I think, if we let us put this data together, I think it's a very interesting data that those who get AF have a poorly contracting appendage and it has a low velocity. And you guys have a lot more volume than us in AF, so maybe you also need to start looking at this. We could do a joint study.
Indeed.
But I think there's a lot of aspect and discussion to this, that you can actually work out a predictor, which we work out with the CHAD score and CHAD-VAS, that this velocity across an appendage can be a predictor for future thromboembolism in AF.
Absolutely, sir. And just to illustrate, I mean, this is where I'm saying AF begets AF. I think we all agree with, when fibrosis sets in, I don't think anyone can reverse it unless we get a heart transplantation to some extent. So that's why before it sets in, the substrate is there. We nip it in the bud, so that the myocyte, its integrity is maintained, and obviously contractility. But absolutely, this is where the gaps in evidence are, and hence we need to work on this to actually improve the outcomes.
And would you recommend a routine maze procedure or its modification in a patient who undergoes a bypass, because eventually they would need, some of them would need it, and there's really no downside to a maze?
So I think, so basically what the guidelines say as well, and they prove, if a patient is to undergo cardiac surgery, and they are to go something in the LA, for example, for mitral valve replacement, etc., they should be considered for these more complex surgical procedures on the table in the same go. Obviously, then it's for the surgeons to devise with their experience and everything. LA isolation, left atrial appendage isolation, if that can be ligated off, that will be very good. If obviously the maze procedure can be done, the basically combined effort of an EP guy and with a surgical person, so obviously that will obviously reduce the burden of AF even after surgery. So because at the end of the day, this pool of AF, we have to stop the introduction of new patients coming into it, and we have to deal with the patients who already have it. So we have to reduce that pool to decrease the burden on our community, sir.
I just want to take the last minute of your side. Thank you very much. It was an excellent talk. I want to say, if we have a patient who is having the dilated LA and having some thrombus present in the left atrium, what are the guidelines just to right now treat this left atrial thrombus? Either we go with the VKA or something DOAC. What's the recommended for this treatment? Secondly, what are the chances and proportions of developing the left atrial thrombus, either with the lower control atrial fibrillation or within the higher rates? Where are the higher chances of developing the left atrial thrombus, either with the low rate or the high rate? Please.
Right. So two things. So what do the guidelines say? If a patient has mitral valve prosthesis or has basically moderate to severe mitral stenosis, the recommendations as they stand is vitamin K antagonists. Whereas if a patient has otherwise NOACs or DOACs, these are the way forward. The second question goes, atrial fibrillation is always very fast. It's the ventricular rate that is reduced. So atrial fibrillation is always ticking at almost about 280, 290, 300 beats per minute plus. So what we're doing as clinicians, what we see on the ECG is actually a reduction in the ventricular rate. So we give beta blockers, we give amiodarone, we give these things. It does not change the dynamics significantly of basically the atrium. It's the ventricle that we're seeing. So regardless of that, there's not much data, but having said this, because it holds hardly a bearing on the atrial fibrillation rates, it won't be that. But we know the faster it is, the less contraction, more fibrosis, and basically more.
And lastly, how much early we just need to refer to
I
the...
think in the
Sir,
interest
because of the
time,
brevity of time, we will restrict the question answers to the end of the sessions. And I now thank you, sir, for your detailed discussion. And now I request Professor Dr. Abdul Manan, Assistant Professor, Consultant Electrophysiologist at PIC Lahore, to share his views about the interesting topic of when I should worry about PVCs, evaluation and practical management of PVCs.
This one? Slide आगे पीछे इधर से. Bismillahirrahmanirrahim. Rabbi zidni ilma. Thank you very much for the kind introduction and invitation. So actually my presentation is a face of all the electrophysiology department under the umbrella of Pak Heart Rhythm Society. So I have made my talk very interactive and case-based so that everyone has a take-home messages at the end of my talk. And I have limited my talk just to 8 to 10 slides, and I'll try my best to complete my talk in next 10 to 12 minutes. So, unfortunately, you know, it's a very big topic, and I have limited my talk just on the idiopathic outflow tract PVCs, and I have made actually a case-based presentation. So I'll share the initial evaluation that how can we go for those patients who are having idiopathic outflow tract PVCs, that what's the minimum workup for the cardiologist that they should have to make the correct diagnosis, and what are the indications of ablation therapy in those patients who are having outflow tract PVCs. In this talk, I'll not discuss those PVCs which are actually in the setting of structural heart disease, that may be ischemic and a non-ischemic. And I'll not discuss those PVCs which are there in the normal heart, especially PAP muscles, fascicular PVCs, and all those. So coming to the question, what's the practical approach for those patients who are having a structurally normal heart and their PVCs, they are coming from the outflow tract. So a 31-year-old male smoker who came to our OPD with a history of sustained palpitations for last few years. His echocardiogram was done and the ejection fraction was 34%. So the patient was referred to us for ICG. His cardiac MRI revealed no scar and the patient has a normal myocardial perfusion imaging. So everyone can appreciate that the patient has LBB morphology in lead V1, and if we just look at the QRS polarity, especially in the inferior leads, they all are positive. We can appreciate that all the PVCs, they have the same morphology and they have the same coupling interval. So definitely we are dealing something that the patient has a frequent PVCs. As far as the localization is concerned, that's most coming from the RVOT. Now the question is whether this PVC is a cause of this low ejection fraction, or maybe this cardiomyopathy may be the cause of these frequent focal PVCs. Now the second patient, who again presented to us with history of recurrent palpitations and dizzy spells, but in this scenario the patient has a normal ejection fraction, no other comorbid conditions. And as I earlier said, these are the two important leads, lead V1 and the inferior leads. So everyone can appreciate that there is initial R wave, so it means that something is coming away from the RV, that's the LVOT, and all the QRS complexes, they are positive in inferior leads. It means that they are coming from the left ventricular outflow tract. So now, this is how we will take these patients in our PVC workup. As I earlier said that in this limited time, I'll discuss and I'll focus only on those patients who are having outflow tract PVCs, and I'll not discuss the other ones. So whenever we ask the patient, okay, you have a premature ventricular contractions, but the patient will say, no, I have a skipped beat. I have extra beat. So now why it's so? What's the pathophysiological mechanism behind these PVCs? Why the patient feel different from our concept? So we normally know that whenever we have a normal sinus node and an AV node, his per congestive system conduction, we have a normal PQRS complex. And whenever we have anything that's coming from the outflow tract, what will be the hemodynamic manifestation of these ventricular contractions? So here is actually we can appreciate all these sinus beats, and here we have a PVC. That's a premature ventricular contraction that happens especially in the refractory period. So if you just look at the pulse and the blood pressure, it means that over here, the cardiac contraction is very weak. That's the reason the patient will say that I have an extra or a skipped beat. But once there is a more filling of the ventricles, you know, ventricles just work as a rubber band. You will stretch it more, it will squeeze more with a more power. So once you have a PVC that comes early, it will give a very weak pulse, and even the patient will not feel it. But in this compensatory pass, there is more filling of the ventricles, and that will give a very forceful contraction. Maybe that's what's the manifestation of the PVC that's taken by the patient, and not this is the actual PVC that's taken by the patient as a skipped beat. So what are the other clinical manifestations of these PVCs? The patient can present with presyncope, depending on the numbers and the hemodynamics, palpitations, even the chest pain, and sometimes these PVCs, they are actually can cause intraventricular dysynchrony. Whenever there is ventricular contraction against the closed valves, then definitely there is a decreased cardiac output. In that situation, the patient will complain of easy fatigability, dyspnea, lethargy, especially if the patient has a very high PVC burden. So now coming to our cases, so these are the two important leads that every cardiologist has to look for. Okay? So now these inferior leads, they will guide us whether we are dealing from the top ventricular chambers or from the bottom ventricular chambers. And this lead V1, it will give you the guide whether you are dealing something that is close to the RVOT or anything that's away from here. Suppose if the site of the origin of the PVC is from RVOT, you will find left bundle branch morphology complex, especially in the lead V1. Anything that's away from here, especially the lateral mitral annulus, then the wave of depolarization will move towards lead V1. In that situation, in lead V1, you will find positive QRS complex. So lead V1 is very, very important to know whether you are dealing with the right-sided outflow tract or the left-sided. And what's about the top and the bottom? So anything that's positive, especially in the inferior leads, it means that something is coming from the superior part of the outflow tract. So here you can appreciate, you may have RVOT, LVOT, even the proximal aortic root, even the LV summit region. So all the PVCs, if they will happen from here, all they will point towards the inferior leads. In that situation, you will find positive QRS complexes in the inferior leads. So everyone has to concentrate especially on the lead V1 and the inferior leads. So now, in our first case, once we have taken the Holter monitoring of this patient, everyone can appreciate sustained episodes of normal heart RVOT VT. Here in a LVOT PVC case, the PVC burden that was around more than 20,000. But the patient has structurally normal heart over here, but here the patient has reduced ejection fraction. So whether the patient has a PVC-induced cardiomyopathy, yes or no, we already have taken the cardiac MRI, and yes, the patient doesn't have any scar over there, and the patient has RVOT VT in a setting of PVC-induced cardiomyopathy, and in the second case, high PVC burden with the normal heart. So this is a very, very important slide just to know what's the 2019 HRS consensus document, that how we have to take over these patients if they have a normal heart or they have a PVC-induced cardiomyopathy. What are the treatment recommendations for these patients? So in patients with frequent and symptomatic PVCs originating from the RVOT, in an otherwise normal heart, catheter ablation is recommended in preference to beta blockers and class 1C. In patients with symptomatic ventricular arrhythmias from the RVOT in a normal heart, especially once the patient is on AV nodal blocking drugs, but the patient is not tolerating or there is an ineffective response of those drugs, Even then, there is a class 1 recommendations to refer these patients to electrophysiologists for the PVC ablation. So it's very, very important to understand earlier in the course, especially in these patients, that it's almost a curative with a success rate of around more than 90% in a setting of RVOT-VT or a PVCs, and around 80 to 90%, especially with the LVOT PVCs and LVOT-VT. So what we did, so in our first case, once we have taken this case in our lab, you can appreciate the patient as a sustained episodes of a RVOT-VT. We have taken the 3D that will reconstruct the map, and it will guide us where the site of origin, and this was the site of origin, and even now the single burn has changed the life of the patient. Now in our follow-up, this is the ECG, the same patient that was taken after 3 months, free from PVCs, Holter revealed only less than 1% PVCs, and the ejection fraction over a period of 6 months has improved to 56%. So it's very, very important to take these patients, especially for early referral and ablation. So the second patient and the source was very close to the coronaries, and we, again with the 3D guided ablation, we have taken the success, especially in this LVOT PVCs near the coronaries. So take home message for cardiologist, early referral to electrophysiologist for evaluation and ablation of all PVC cases in general, maybe in a setting of structural heart disease, ischemic, non-ischemic, okay? And normal heart PVCs, especially with a high burden and those young patients with a high PVC burden and they are very symptomatic, rather than to offer them in a long-term AV nodal blocking drugs, it's better to refer them at least for the evaluation to electrophysiologists from your center. Especially when the site of origin is from RVOT and LVOT with a very high success rate, and that's based on the guidelines, there is a class 1 recommendations. Thank you very much.
Manan, a quick comment and a quick questions as well. Now, I know your center is doing remarkable work in terms of this curative treatment. We both know that this is cure for these ectopies, which are very dreaded. Do you do all of these outflow ectopy ablation with mapping system, or you do conventional ablation as well?
Now unfortunately, previously once we don't have these special 3D tools, we always offer the patients, okay, if the patient has a normal heart and we just have to take the single catheter in RVOT and just to map. But unfortunately, that's not the truly precise method of dealing these patients, where we know that if we just have to lower the radiation hazards and the burden, and we have a very high success rate in that situation, it's mandatory for all the patients who have RVOT or LVOT PVCs for a very high success rate and for a precise localization of these PVCs. Most of the time, ECG is actually a crude method to have a localization, okay, that's from RVOT. But RVOT is a 3-dimensional structure. That may be septal, that may be free wall, that may be posterior, that may be, you can say, lateral. And sometimes you have something that's very close to the, in the vicinity of the coronaries. So there is a high risk of collateral damage. So 3D will guide you precisely, okay? You are in contact with the abnormal focus over there, and you can minimize the collateral damage. So I think, especially in any center who has a 3D facility, it's mandatory to take these patients right from the beginning rather than to take as a redo case.
Dr. Manan, usually they say that the RVOT PVCs are benign.
It depends on. Normally they are benign, but as I earlier mentioned, the patient has an ejection fraction of 34%. So when we will say that it's not benign, it depends on, suppose if the PVC burden is more than 10%, number one, or if the if the patient is very symptomatic despite of taking the beta blockers, or if the patient is having LV dysfunction. In that situation, it's not benign. If the patient has a PVC burden of less than 5%, and the patient is not on long-term AV nodal blocking drugs, in that situation, yes. We all have the PVCs, but it all depends on the symptomatology and the burden.
Excuse me, one comment. Actually, I don't agree with Dr. Manan that 3D is mandatory for ablation of VPCs. I always prefer to go first with conventional, and I believe conventional signals are much better than 3D.
Unfortunately, whenever we have to present anything, we have to assume
In our
that we
setup-
are presenting something at international forum, okay? It's not, it's all about this forum. So if I'll take the same statement, it's not because something is against me, no, it's not like that. So if something is very close to maybe my friend or like my dad, so what's my preference? Whether I'll take the conventional way of dealing those PVCs, once I am planning for ablation, or I'll take the 3D. It's not all about the cost.
Actually, हमारे setup में 3D cost would be around 2 million per patient, which is not affordable, or 90% of patients, due to cost, they will not have access to you. My point of view is this: patient should be offered ablation whenever is needed. We do need to consider the cost.
Sorry,
Sir,
go ahead.
Sir Ismat knows me. I always do on conventional, and there is recurrence rate is very low, because local conventional signals guides you much better as compared to 3D.
Actually, it's not a debate between
Dr.
conventional
Manan,
and
sorry.
3D. Whatever the mean you will use, you always try your best to give the maximum benefit
Dr.
to the
Manan,
patient.
sorry, just to give Professor Harun Babar an answer. Sir, both Talha talk about AF and Manan talk about this ectopy. The gist of the presentation is that if you offer an ablation as early as possible, you cure them.
That is the bottom line.
Yeah, that's the bottom line. So he can cure these outflow ectopies just like that. And what Talha was trying to tell was, ablation is a cure for AF and paroxysmal. The earlier you do it, the better it is. The mapping systems or non-mapping system, that is obviously depending on the cost. But the earlier the ablation, the better it is. Hence the answer to your question of benign versus non-benign.
Thank you. The last controversy. Catheter ablation or 3D mapping, which is standard of care? Keep aside the cost. What is standard of care? What is guidance?
Sir, what Shabir was trying to tell was that in our setup and society, because of the financial issues, this is not mandatory that you go. What Manan was saying was that because of the closeness of the focus to a left main stem, and because of a too much exposure radiation, if he does it with the mapping system, the safety is enhanced.
It means the mapping system is standard of care. And
Yep.
If it is available in a center.
It's standard, your method.
Sir, can I just, so thank you, Dr. Manan. Basic thing is this, sir, वही जो Sir Azmat ने जिक्र किया, the earlier the better. क्योंकि दो चीजें हैं. As a patient, if I'm on the other side of the table, do I want a chronic treatment or do I want a cure? And obviously with the risks and benefits that come with it. Obviously modalities is for the clinician to decide whatever is available, whatever he's comfortable, he finds it. Maybe it's in a very complex area, it might be he needs the 3D, he may do it with the conventional. So it varies in every way. But the beautiful thing is this, we have cures available. Medicine में तो चीज़ों के कितने चीज़ों का cure है? Hardly anything. But really, if we have cures now over the past decades, AFIC has been leading the way, and mashallah, I think we're all indebted to this institution. So we can offer and we must offer, and that's where I was saying this shared decision making for anything. So I just wanted to make this comment. So I really think what Manan has said, absolutely. A दूसरी चीज़ says यही चीज़ है, symptomatic PVCs, patient doesn't want that, he can just everything skip, go for the catheter ablation. और जब patient को आप reasonable time देके समझा देते हैं, तो patient inevitably, I mean, I just try to empathize. If I was there, what would I want? I would just say, fine, get rid of it. But nevertheless,
Actually,
Actually,
this thing. जो मेरा point of view है सर, ये है कि बहुत सारे patients हैं जो cost की वजह से available इसको procedure नहीं करा सकते. अब सिर्फ 3D ना होने की वजह से हम उसको procedure no करें या decline करें, that is my point of view. कि 90% ऑफ पेशेंट्स जो हैं वो हमारे, हम ये कहें कि हम 3D नहीं करेंगे आपका जब तक आपकी कॉस्ट पूरी नहीं होगी, तो ये ठीक नहीं है, आप कन्वेंशनल ट्राई करें उसमें.
इसका मतलब ये है कि जो समझ आई है कि 3D मैपिंग से एब्लेशन करना इज नंबर 1 ट्रीटमेंट, लेकिन इट्स मोर कॉस्टली. लेकिन अगर वो अवेलेबल ना हो तो हमें पेशेंट्स को जो प्लेन रूटीन जो क्लासिकल है ईपी वो भी कर देनी चाहिए. इट इज आल्सो क्वाइट इफेक्टिव.
जी सर.
Thank you, sir, for your brilliant presentation.
It's very safe.
Sir, should I proceed to the last presentation? So the last presentation of the present session, I will be delivering it myself. The topic is, slide लगा दें, कहाँ से करेगा? कहाँ से start होगा? Slide यहाँ से करूँ? नहीं हुआ होगा, कहाँ हुआ है? कहाँ से start करूँ? हाँ, नहीं वहाँ पे नहीं आ रहा. ठीक है. Switch कर लें. हाँ, ठीक है. The topic of present presentation is perioperative management of patients with cardiac implantable electronic devices. The number of patients undergoing cardiac implantation of devices is increasing and has exponentially increased over the last 2 decades, and so has the number of these patients undergoing various surgeries. The perioperative management of these patients needs to be individualized to the patient, type of device, and the procedure that is being performed. The main concern during the peri-op management period is that of electromagnetic interference. It can cause problems of oversensing, resetting of device to factory settings, permanent damage to the pulse generator, and upper rate behavior. The most frequent interaction of the devices with electromagnetic interference is that of oversensing. The oversensing can lead to underpacing. The underpacing can lead to pacemaker inhibition in case of pacemakers. Apart from inhibiting pacing in ICDs, it can also lead to inappropriate detection of tachyarrhythmias with inappropriate ICD shock deliveries and ATPs. The risk factors of oversensing depends on anatomical site of electrosurgery, duration of electrosurgery, and the position of return electrode. Limiting electrosurgery to procedures below the umbilicus, limiting usage to short bursts, keeping the current path at least 6 inches away from the device with return electrode placed on lower body can mitigate these problems. The upper rate behavior in the case of patients' response to electromagnetic interference occurs in case of patients having rate response sensors, specifically using impedance-based sensors, example, minute ventilation sensors. It causes the device to work at the upper rate limit. The device can be reset to factory settings in case of major hardware failure that occurs in case of exposure to therapeutic radiations and cardioversions. The device paces with high voltage treatment in VVI pacing mode. The different manufacturers have their own preset and pre-programmed pacing modes and pacing outputs for the reset mode in both pacemakers and ICDs. The permanent damage of the pulse generator can occur if the electrosurgery is applied directly over the pulse generator or in case of exposure to monopolar electrosurgery in close proximity. Now, how can the effects of electromagnetic interference during the surgery can be mitigated? It can be mitigated by avoiding using of monopolar electrosurgery and using bipolar electrosurgery instead, restricting the electrosurgery to procedures below the umbilicus, keeping the path of current away from the device, minimizing the exposure to monopolar electrosurgery to short bursts of less than 5 seconds, using magnet or reprogramming the device before the procedure, and avoiding unipolar sensing polarity. The various sources of electromagnetic interference that can be encountered during the surgery are the monopolar electrosurgery, radiofrequency ablations, therapeutic radiations, electroconvulsive treatments, TENS treatment, and cardioversions. We will be discussing some of the special situations. The cardioversion can cause major hardware failure, and it can be avoided by placing the electrodes in anterior-posterior position with at least 8 cm between the anterior electrode and the device. The diagnostic radiation, although can interfere with device functioning, however, no additional recommendations for device interrogation are made beyond that performed as a part of routine follow-up. The therapeutic radiation can also cause major hardware failure, inappropriate shocks, and loss of pacing. The effects are worse if the radiation is applied directly over the chest and high dose of radiation is used. The effect can be mitigated by avoiding direct exposure of radiation over the device, reducing the dose of radiation, repositioning of the pulse generator if it falls within the radiation field, and reprogramming the device after each large radiation exposure. The main concern during the surgeries is that of exposure to monopolar electrosurgery, that is in procedures above the umbilicus. It is especially of concern in case of patients with defibrillators and in case of pacemaker-dependent patients. The effects are mitigated by reprogramming the device to inactive treatment in case of ICDs. A magnet can be applied, limiting the electrosurgical procedure to short electrosurgical bursts and placing the return electrode away from the device, and the rate response sensor should be turned off. In case of gastroenterology procedures, including endoscopies, colonoscopies, and procedures using ICDs, along with procedures using ECTs and TENS, recommendation the same as for procedures using monopolar electrosurgery above the umbilicus. The main concern in ECT treatment is that of oversensing of myopotentials. In TENS, it can interfere with the pacemaker and ICD function, and it is not recommended in case of patients who are pacemaker dependent or ICD dependent. And it should be avoided in case of thoracic region and adjacent region. Now the procedures below the umbilicus with ICD. In these cases, prophylactic magnet application can be done or reprogramming can be done as an alternate to no treatment at all. However, no magnet placement or reprogramming is needed in case of procedures below the umbilicus in case of pacemakers. In some special situations like EMG, NCS, lithotripsy, dental procedures, lower extremity surgeries, and capsule endoscopy, reprogramming and magnet application is not recommended. Since I have been discussing about magnet placement in the previous slides, I would be briefly touching the magnet response and how it works. The magnet, a 90 Gauss magnet, can be placed over the device directly in case of Medtronic, Boston Scientific, and Biotronic devices, and it is placed off-center in Sorin and St. Jude's devices. The magnet works by causing activation of the magnet reed switch. When the magnet reed switch is in closed position, it causes the magnet response to occur. The magnet response in ICDs causes the tachy detection to be disabled. So no tachy treatment like ATP or ICD shocks will be delivered. However, it does not affect the anti-Brady pacing in case of ICDs. The pacing mode will not be changed in ICDs. The magnet response in pacemakers is different. It causes the pacemaker to switch to asynchronous pacing mode at higher pacing output, and it inhibits the rate response in the pacemakers. The asynchronous pacing mode depends on the pre-programmed pacing mode of the pacemaker. If the patient was pacing with AAI, it is switched to AOO, VVI is switched to VOO, and DDD is switched to DOO. Now, for example, if the patient is switched to VOO mode, the first alphabet represents the chamber paced is the ventricle. The second alphabet, the chamber sensed, is none of the chamber is sensed. And the third alphabet that represents the response to sensing, that is inhibition or tracking, it is also absent. So there will be no response to sensing. So what will happen is the pacemaker will keep on pacing at fixed rate regardless of patient's intrinsic QRS complexes. It can lead to pacemaker spike on the vulnerable period in the T wave, leading to R1T phenomena and VT VFib. So the important take-home message in this is that the magnet mode, although it can prevent from inhibition of pacing in pacemaker-dependent patients, but it can predispose the patient to VT and VFib, so it should be limited to the minimum time possible, and it's absolutely required. Similarly, in case of DOO mode, the chamber paced is both the atria and ventricle, none of the chamber is sensed, and the response to sensing is off. Pacemaker keeps on pacing both the atria and ventricles regardless of patient intrinsic QRS complexes, and again patient is exposed to predisposition to VT VFib. I will not be going deeply into the slide. This is just to show that placement of magnet over the pacemaker generator initiates different magnet responses that are peculiar to the specific manufacturer. Similarly, the magnet response in different manufacturers is also different in ICD devices. The Medtronic and Boston Scientific have audio response as well as on magnet placement. There will be beeping sounds when the magnet is placed. And some of the devices need to be turned on the magnet function before the magnet effect can take place. For example, in Boston Scientific and St. Jude's devices, we need to switch the pacemaker to on position before the magnet response can occur. The other devices do not need them to be turned on to the magnet response to occur. Once the magnet is removed, the device reverts back to the pre-programmed rate. However, if we place a magnet and no magnet response occurs, it can either mean that the battery life is low, the pacemaker is programmed to ignore the magnet, or the pacemaker generator is deeper inside submuscular implants, or patient is very obese so that magnetic field does not reach the generator. I will be briefly going through the perioperative evaluation of patients. In emergency procedures, we need to know about two things: what type of device is used and whether the patient is pacing dependent. The type of device can be evaluated through the medical records and examination of the chest radiographs. Different devices appear differently on the chest radiographs. I won't be going into details. And whether the patient is pacing dependent is determined from the 12-lead ECG in emergency situation. If the pacing spikes occur before most of the complexes on a 12-lead ECG, we will assume that the patient is pacing dependent, and we will take it as such. In case if the patient is pacing dependent or has a defibrillator and is undergoing emergency surgery, we need to follow the following steps, that is short electrosurgical burst, magnet placement over the device for procedure above the umbilicus, magnet available for procedures below the umbilicus, monitoring of the patient with arterial line and plethysmography apart from telemetric recording, placement of refibrillation pads in AP position, and re-evaluation of the device before the patient leaves the surgical environment. In elective cases, the device should be programmed or checked at least within 12 months in pacemakers and 6 months in ICDs and CRTs. The information that needs to be provided to the physician dealing with the device is the type of procedure, site of procedure, monopolar electrosurgery is used or not, cardioversion will be used or not, and whether hemodynamic challenges will be faced. The information that needs to be provided to the operative team includes the date of interrogation, type, manufacturer, and model of the device. Battery longevity is very important and is documented as 3 months because that represents the end of elective replacement index. And any leads that are less than 3 months old because there's high chance of lead displacement. Other information is also includes pacing mode, whether ICD treatment is turned off, whether rate response sensors are turned off, what will be the response of patient to magnet application. During intra-op procedure, the patient with ICDs and pacemakers with large electromagnetic exposure to monopolar electrosurgery or RFA in procedures above umbilicus should be turned to asynchronous mode. The device should be re-evaluated at different times immediately after discharge in cardioversion, radiofrequency ablations, and therapeutic radiations, and after a month in monopolar electrosurgery, ECT, and lithotripsy. And also, if the device was reprogrammed before the procedure, if there was a hemodynamically challenging procedure, if large exposure to AMI was occurred, and if there is logistic problems limiting the patient follow-up within a month. The key points is that EMI encountered in operation theater can interfere with device function. Bipolar diathermy should be used in preference to monopolar electrodiathermy. Degree of dependency of device should be ascertained before the procedure. The defibrillator function of ICD should be deactivated, and device should be reprogrammed or magnet should be applied in case of monopolar electrosurgery above the umbilicus. Pacemaker-dependent patients should not be programmed in unipolar sensing modes. So I will be closing this discussion.
Thank you. Thank you, Kanasobia, for your very elaborate presentation. In the interest of time, and our surgical colleagues are waiting for quite some time now, I'll just request Professor Shahbaz Qureshi for his brief comments on the session that we just held, and with this we'll hand over to the surgeons.
Thank you very much. I think the presentations were excellent, starting with the narrow complex and the wide complex tachycardias, atrial fibrillation from Talha, and the PVC's ablation by Dr. Saab from Lahore. And the last was regards the ICD, and I think the reason why Azmat has asked me, there are more reasons than one. So it's important that we evaluate the ICDs regularly at 6 monthly interval and to determine the life in these patients. And I learned a lot in this session, and I think it was excellent. Thank you to all the presenters.